Hi there, this is Dr. Abbott and Kelly Boardman. We're here to talk to you a little bit more about the COVID crisis. So today we're going to talk about masks and medications. So this is my mask. It's one of the very few that I have because I only have like a half of a box to get me through this entire crisis. All of our orders are either back ordered or just being canceled. They're kind of hard to get. But remember, this mask is not an N95. It was really created not to protect me. Remember, these masks, the one that Kelly there is wearing, is made to protect the patient. They were used in the setting where if I'm operating on somebody and I sneeze, we don't want to blow up the field, right? We don't want the cough all over the patient who's being operated on. So when you wear a mask, it's not because it's going to do much to protect you. Where, there's too much airflow, I don't know if you can see all this airflow, to really be protective. Even the N95 masks are only 95% if they're worn perfectly and fitted perfectly. These things don't come close to that.
Can you show that one more time, how you put it on?
So normally you hold it, you try not to touch the mask, especially the inside, and you put it on by the straps.
But more how you want to start at the top.
And you do try to fit it if you have a medical mask, but hopefully you're using bandanas and cloth materials as per CDC guidance. So remember, if you wear a mask, and if everyone wears a mask, then all the sneezes and coughs stop becoming as communicable, right? And that's what we're trying to do. If Kelly wears her mask, she's protecting me, right? If I wear my mask, I'm protecting her. She's not protected at all for herself by wearing that mask. Okay, so that's the first thing. Past masks, we want to talk about medications. And again, anything I tell you, you should run by your own physician because every clinical situation is differently. This is mostly for my own patients so that they have an idea of what I'm thinking at this moment in time because what keeps happening changes. Okay. The first, we'll talk about steroids. A lot of times when people have trouble breathing, like if you think about asthma, steroids are the thing that we prescribe. The problem is, as far as we can tell, COVID patients who are given steroids do worse. So we try super hard not to give people steroids in this particular setting. Okay? Now, if you're asthmatic and you're having an asthma attack, we're going to give you steroids. So if you're an asthma patient and you have a peak flow meter and you tell us your peak flow dropped from 500 to 250 and you're wheezing, you'll probably benefit from steroids, and that's what we should be doing. If you're a COVID patient and you're just having trouble breathing, you don't have a history of asthma, you don't have a history of allergies, you don't have a family history of asthma, then steroids are probably to be averted. Don't do it. What we don't know anything about is inhaled steroids. And again, I think, if you have that family history of asthma or a personal history of asthma and you're having trouble breathing, and this is allergy season because it's April, you should probably check your peak flows and take your medication. But there's no actual literature to suggest what to do one way or another. So steroids, especially the pills, are to be avoided in older patients who have no asthma history, who we think have COVID at this point in time.
Yep.
I wasn't sure if you had any comments or not. The second thing are non-steroidals. If you're taking Aleve, Motrin, don't. Again, no proof. And there are some recommendations made by people with much bigger names like Harvard University who think that it may be safe to take non-steroidals, which is Aleve, Motrin, ibuprofen, Advil, meloxicam, Voltaren, Dapro, to mention a few names. But it all centers around how this coronavirus enters your cells. It enters the cells through a receptor that's involved in hypertension, among other things as well. That's why people get GI upset as well. There are some of those receptors in the GI tract. But it's really in that one receptor that is central to how blood pressure is regulated. And we know for years that if you have high blood pressure and you take high doses of Aleve or Motrin, your blood pressure control goes down because of the non-steroidal interaction on that receptor. But for now, if you're having horrible pain and you're having terrible cramps and nothing else is working, take your medicine. But if you can get by with Tylenol, if you can get by with ice, if you can get by with a little bit less pain relief, Tylenol is definitely a better bet. All right? And the last sort of medication thing that comes up is hypertension itself. As I said, I'm not trying to go into the molecular physiology of it. There's some great YouTube videos if you want to go find them. But really, when they're done explaining it, you have a whole chart of all the interactions between this receptor, and it's pretty complicated. At low levels, something happens. At high levels, something exactly opposite happens. And so they're trying to theorize if, you know, should we, since we know it's acting on these blood pressure receptors, should we, you know, stop taking blood pressure medicines? And again, most people who've looked at this, you know, critically have suggested that you're probably way better off to continue to take your blood pressure pills. The reason is a couple. One is all of these complex flow sheets that you'll see online being created, they're mostly based on animal models, right? And what happens in animals doesn't necessarily happen in humans. So it's a guess at best. The second thing I took from looking at those lectures is that most of the negative effects were seen in animal models. Most of the positive effects seen by taking your blood pressure medicines we're seeing in natural human studies. But the studies are minimal, they're just observational, they're not randomized controlled, there's just 10, 15, 20, 30 people's experiences. It's not a lot of great information. But what we do know is high blood pressure seems to be the leading cause of the severe, not the cause, that's the wrong word. 70% of patients who die have high blood pressure. The people who die have this severe inflammatory storm. So there's some sort of potential connection there. We don't know how to characterize it. It's probably best for you to control your blood pressure and avoid that severe inflammatory response than stop the medicine and have a super high blood pressure, right? Plus, look at the numbers. Even in the US, we're talking, I don't remember the last time, 10, 20,000 deaths. We lose a lot more than that from heart attacks and strokes, right? So we will lose people either way, but I think we'll lose people a lot more if you don't take your blood pressure medicine. Again, just an opinion based on very preliminary anecdotal information. I have yet to see a formal recommendation by any country, any world CDC that says, hey, stop your blood pressure medicine. I have not seen that anywhere. And it would probably
I've seen the opposite, where people are recommending you keep taking your daily medications.
Yeah, we have seen some people come out and say that for sure, some governments. So take your blood pressure medicine, try to change your pain control strategies if you can, right? And if you're asthmatic, you should take your steroids. Breathing is first. If you're not asthmatic, inhalers, especially steroid inhalers and steroids, are probably sort of not in your best interest. Anything you want to add?
Nope. Thanks, guys. Stay home. Stay healthy.
Stay safe.